welcome you all to Fireside Chats. I was hoping there'll be some fire in the corner, but there isn't. But we have 30 minutes thereabouts to talk about pandemic preparedness, talk about the 100-day mission, um, and I hope we're not just preaching to the choir here. But I think we're quite starstruck having Stephanie here with us. So maybe you tell us a bit about who you work for. Everybody knows Find, and I have a few questions, and then we can have a quick chat.
Okay, well, thank you so much for having me. As I said to Emmanuel beforehand, I am not an expert on diagnostics. I have a broader perspective that I hope to bring to the conversation, but you all are the experts, and Emmanuel certainly is an expert. So I'm hoping this can be a dialogue rather than, me just sharing information. That's probably less interesting than what you have to share. So let me start by saying that I am the United States Coordinator for Global Health Security. I was appointed by President Biden to serve in that role earlier this year, but I have been at the National Security Council at the White House for the last almost 2 years, working on a range of global health issues, and now obviously focus on global health security, but I definitely have a broader background and perspective in global health. And before that, I was at the Department of Health and Human Services, and before that, I was in the research world. So I was working on research to inform policymakers without ever having been a policymaker. And now that I have been a policymaker, I have a very different perspective on the types of information and the way to synthesize information to inform policymakers. So happy to share those thoughts.
Thank you very much. Just to set the stage a little bit, Find has been working with the IPPS, on the 100-day mission work, and a lot of there's a roadmap. I'm sure you're aware. If you check the Find website, it's there, and you also the independent, and also really there's a roadmap looking at the diagnostic. Um, the diagnostic framework that is required to ensure that we have the diagnostics in place for the 100-day mission. And essentially, over the last year, there have been a few things developed. So there's been the report, the diagnostics report that has been out as well. We can share, I think, links to that. There's also a report, the 100-day scorecard that looks at funding available, as well as interventions and support that's been put in place, essentially for diagnostics, therapeutics, and vaccines. And I think our conversation today will really look at that in some depth. But we'll also like to know a little bit about the work you're doing and see how it can support the aspirations that we're aiming towards. But to get it off the ground, there's a recent huge document that was launched. Your team launched the Global Health Security Strategy. Could you tell us a little bit about what that includes and how that can impact preparedness globally?
Sure. So last month, it feels like a much longer time ago, but last month in April, we launched the new United States Global Health Security Strategy. It's a 5-year strategy that's forward looking. The previous strategy was released in the previous administration. And in a lot of ways, this strategy is not dramatically different from the last strategy, which I think underlines we've gotten a lot of questions. I know in the US and around the world, there are upcoming elections, a lot of questions about what that means for our work in global health security. I think there's a very strong case to be made that there has been and hopefully will continue to be strong support from all parts of the political system in the United States for this work, because there is a very clear case about why these investments are essential to protect the American people, just like there's a clear case for why these investments are essential to protect people in other countries. The strategy that we launched lays out really explicitly some of the lessons learned from the COVID pandemic, and then 3 goals to build on those lessons learned. So the first goal is investing in our bilateral partnerships and expanding bilateral partnerships. So we announced that we have built partnerships with 50 countries around the world. And this is not, just sort of traditional development investments. This is, we sat down and talked to the governments of each of those countries directly about where they have gaps in their international health regulations capacities and which gaps they would like to work together to fill. So we identified a shared set of gaps. We have very clear metrics for progress toward closing those gaps. And again, they were identified in partnership with those governments. So the list of governments and the gaps we're working to fill are on our website. You can get all of that information. I'm happy to share it. The second goal in the strategy is financing and political will, and just I think the reality that we hear over and over again. And I'm sure many of you have spent quite a bit of time across the street in the last few days listening to conversations and debates about the lack of sufficient financing for pandemic preparedness and response. And we acknowledge and agree with this estimate that we need about $10 billion every year in international financing to fill the gap, and are working very hard in a number of different ways to try to fill that gap as much as we can ourselves, but also to bring in other donors to fill that gap. The third area in the strategy is looking at linkages and areas of reinforcement between different investments by the US government. So obviously other areas of global health, and we think and talk a lot about the PEPFAR program that has invested over $100 billion in the last 20 years on the HIV/AIDS response. But through those investments has built up, for example, stronger laboratory capacity that was leveraged during the COVID response. So where else can we leverage the investments we're making in animal health, in national security more broadly, in a whole range of areas to support our global health security goals? So those are the goals. In terms of the connection, um, we're talking about and describing the partnerships and systems we need to build to address some of these key issues. Building lab capacity, building stronger surveillance is at the top of our list of priority actions. So we lay out how we are doing that currently, but also how we are working with these 50 countries and through multilateral institutions to build out a broader strategy.
Thank you. So the 100-day mission roadmap, which FINE developed, in collaboration with partners, and we're trying to see how we can implement, has about 11 thematic areas that we're working on, all the way from developing test directories, also thinking about novel platforms, the regulatory bottlenecks that are in place, also thinking about, the pull mechanisms for diagnostics. It also includes some thinking and planning around priority families as well. And I think one of the things we've struggled with has been that the downstream stuff is what you're talking about, the support to the countries, leveraging those systems that have been built. But there's also a gap upstream, with development of the test. Some of the work we've done, hopefully we'll launch it soon, is trying to understand where we are with the WHA pathogens, for instance. Do we have a TPP in place? Do we have the diagnostics at L1, L2, L3, which is, at the near point of care, DTs, etc. And we're finding that there's a huge gap, just like we know. However, the funding for the research and development part of things isn't there. And I know that the US has a very complicated tapestry of agencies. So can you tell us a little bit about those agencies, and perhaps how we could leverage that kind of investment to support R&D?
Yes, it's a big question, and I don't want to put everyone to sleep with my description of how the bureaucracy works in the United States. But let me try with a few pieces. I mean, one relatively new development, and there are a few ways that we've made updates during this administration to make sure that we're better prepared for the next pandemic than we were for COVID. But one of those is that this past August, we launched the Office of Pandemic Preparedness and Response Policy at the White House. So it's less than a year old, but it is very focused. I would describe it as sort of the successor to the office that focused on the COVID response. And the idea is to, not just respond to current ongoing emergencies, but to put in place a structure and systems and better preparedness for future specific emergencies, but also just general preparedness that we can leverage in times of any emergency. So not surprisingly, and I was saying to Emmanuel before, I work very, very close with this office, and by that I mean I sometimes meet 4 or 5 times a day with them, so we are very close by. And so not surprisingly, one of the priority areas for what we call them OPPR has been this focus on upstream diagnostics investments. They have actually a full-time staff member who is focused on diagnostics, and I wish he were here, but I've chatted with him. And so I think that is a reflection of both the importance of the issue, but from the point of view of the White House, the need to ensure that we are coordinating strategically across the many departments and agencies that are doing great work here. So let me just run through a few, key stakeholders. So of course, the Department of Health and Human Services has a number of different components. Secretary Becerra was here all week. He just left this morning, representing the broad range of work that they do. But the Centers for Disease Control and Prevention, CDC, is part of HHS. Does a lot of key work, but is the first on the ground very often when there's an outbreak or a novel pathogen and we're trying to figure out what's going on in partnership with governments. The National Institutes of Health is also part of HHS, funding a huge amount of R&D, kind of earlier on R&D research in the United States, but also around the world. And a lot of the research in the United States ends up, informing the development of products that are then used in the US and around the world. BARDA, which is part of the ASPR, which is our Office of Preparedness and Response within HHS, which focuses really more on the immediate research and development for countermeasure development. So those are just, and FDA, of course, which is the regulatory agency also at HHS. So these are all part of HHS, which is the regulatory agency that works in the US to approve products, but also works quite a bit around the world, both to review and approve products that will be imported into the United States, but also to help strengthen regulatory systems around the world. So that is HHS alone. Just to touch on a few others, the Department of Defense does a lot of work on development of countermeasures, not surprisingly from a defense perspective. We have colleagues and partners at the US Department of Agriculture that do a lot of animal health work. So there is a huge, huge number of staff and number of agencies that work on these issues. And part of the goal of OPPR is to bring together that work and prioritize. And ultimately, I think with any of these issues, the hope is that if you prioritize, if you create a clear strategy, if you communicate clearly about that strategy, down the line you end up increasing the resources that are available. But first you have to make a clear case for why it's needed.
Fabulous. I think we have our job cut out. We'll also be trying to do the same kind of coordination across board for the 100-day mission, because I think FIND has been thinking about who are the other critical partners, and this run through is really helpful. And really, we've also been thinking who are the other people we need to talk to. Of course, we have the whole other NGOs, we have governments that are interested, we have also the if you like good or bad guys, I don't know what you call them, the private sector, right? We've been thinking about, what's the role? They do have an important role, I think. And I think FIND has been very good in, working that fine line between working with governments and looking at engaging with private sector to develop, these interventions and look at the platforms that are coming to market. But it's a huge challenge, right? I've been thinking that how do we leverage the huge private sector in the US who receive significant amounts of government funding to do research? How do we leverage private sector as a whole to improve these R&D and make public goods available to LMICs where our work is focused on?
So I'm curious about whether there's anyone in the room from the private sector. All right, so you can chime in and defend yourselves if you disagree with what we're saying. I feel like there's a lot of conversations happening where we're saying the private sector isn't here, they should be at the table. And actually, I think increasingly they are here and coming to the meetings and engaging in the conversations. So look, I think domestically, the president has been very clear and very willing to push back on the private sector, on industry and manufacturers to make sure that medicines and drugs are accessible to Americans at an affordable price. I think there is, in ways that some of our friends here can probably attest, have made them very unhappy or frustrated, but that has been a priority for the president and, will continue to be. At the same time, and I think that work is also important to us around the world, at the same time, it is undeniable that the innovation that the private sector drove and has continued to drive was essential to our response during the COVID pandemic and in many other areas. And so we have to, what we're trying to do is balance this. Like, yes, of course, there are interests driving the private sector that are not always aligned with interests of the public in the United States and interests of people around the world. At the same time, we need them at the table and we need them to be making the investments and doing the work that they are doing so that we have countermeasures quickly, particularly in an emergency. And that's not something that's going to be done by governments alone. They are going to be an essential partner there. So how do we strike this balance? And that means having a very live and honest dialogue back and forth, where sometimes we agree and sometimes we disagree. This has been a topic of discussion in the pandemic accord negotiations, of course, and there's been a lot of, actually interest from the private sector in being more actively involved in those conversations, just to share their perspective, which from our perspective would be valuable. But I think what they have said publicly, due in part to the pressure coming out of those negotiations and the pressure coming out of the COVID pandemic, is that they are willing to set aside a portion of their production during emergencies. They are willing to continue capacity building efforts and investments. There's a whole list of things. Now, there may be questions about whether they will deliver on that, and that's fair. But when there are public statements made, you have an opportunity to hold them accountable, just like you have an opportunity to hold governments accountable. So I think we're not going to make progress by continuing to have conversations about the private sector when they are not in the room, not in the conversation. I think we can have very direct, tough discussions when we're in the room together and solve the problem. That's kind of the broad philosophy about it. I think that we are in the moment, particularly in global health security, and particularly in the space of access to medical countermeasures, not just during emergencies, but in so-called peacetime, when people are dying around the world of illnesses that have countermeasures available, where now's the time to put the asks forward to the private sector and the governments, and philanthropies. But now's the time for the specific asks, and let's see how and when they deliver. I think we need to make the asks very specific, and then see what happens. And that's what we're trying to do in our conversations.
I think that's great. One of the things that also, when we reflect with colleagues, is that so there's the development of innovation, but there's also the adoption of those technologies when they're developed, right? And creating a market for a lot of the interventions or platforms that are developed, and using them in peacetime for pathogens or for routine care, means that those platforms can be easily leveraged for when a pandemic occurs. For instance, we saw, with not naming names, experts and Abbott and all those other platforms that were leveraged during the pandemic in several countries. My interest in I'd still like to hear from you, to share your thoughts on the third goal that you have, in the strategy, which is around leveraging existing investments, right? We're thinking, when you develop these new platforms, when you have an approach where you're looking at, diagnostic, priority families and not necessarily single pathogens, it means that you can develop quite pathogen agnostic interventions, right, that are useful beyond what it is that you are dealing with day to day. And I think it's really important to ensure that the people who do the huge purchasing for AIDS, TB, malaria, and for the other diseases that are more funded at this stage, also think about those kind of platforms that are easily leveraged. Is there a deliberate effort in your planning and your thinking right now with implementing the strategy to do this?
Yes. So as you said, this is the third goal, and it's in global health, but also broader than global health. So I think there are kind of very targeted efforts of, for example, we are watching closely and engaged in the response to the Mpox outbreak in DRC right now. And part of the question has been, let's look at both in DRC but neighboring countries where there are active PEPFAR programs that have built strong lab capacity that could be leveraged for the purposes of surveillance. So I think there are very, in an ongoing way, in ways that people often don't appreciate, we are leveraging those investments. One of the challenges, and actually another, to your point, PEPFAR and PMI, the President's Malaria Initiative, has been doing this for a long time. But PEPFAR, a couple of years ago at the Africa Leaders Summit in the US, made an announcement that they were prepared to procure a certain percent of their commodities from regional production, from regional manufacturers, as long as they, pass regulatory approval, et cetera. So this type of, market signaling activity, I think, can be really powerful, even in areas that are disease-specific investments. So the hope is that that drives an increase in diagnostics manufacturing and also for ARVs, so therapeutics manufacturing, that then could be leveraged for other, locally leveraged for other illnesses beyond HIV. So I think there are some really exciting examples, and we are, looking for all the opportunities that we can find, but there is a constraint that we continue to grapple with, which I think others do too, which is that the funding is very disease specific. And that is, the way that it's been structured in the United States for a long time, but not just in the United States. For a lot of donors, it's true. And I think it is partly because it is easier to make the case for money for disease specific issues when you can talk about populations and you can talk about interventions and you can track metrics on how the funding led to an improvement in those metrics. It is harder to make the case for broader funding, that the kind of funding that you're describing, even though I think most people working in this space feel that that is probably a smarter investment and a better way to make sure that we're responding to a range of current and future health threats. So I think that is a real challenge and something that we're hoping to try to grapple with the third goal of our strategy. But as we all know, the way that funding is structured drives a lot in terms of what we're able to do on the ground.
One last question before we open it up for inputs from the audience. I keep thinking, we just to your point, we talk about disease X. The simple part of my mind says maybe we should just go to X and ask them to give us $1 from subscriptions for everyone.
Great, let's do it.
Yeah, but I was going to say that so there are also non-cash incentives that can be given to industry, right, to be more involved in R&D, to incentivize their work, right? And it'll be interesting to hear from you, whether those kind of incentives can include support for tech transfer, support for, capacity building, support also for, beyond just the tech transfer, building the capacity for research in LMITs as well, because it's quite skewed otherwise. So any quick reflections? Then we'll have maybe one or two questions from the audience.
Yes, and again, the industry friends in the audience should chime in on this. I think some of that is happening already. What I would say is, and also one of the lessons learned being on the policymaker side is the more concrete and tangible the ask is, the easier it is to hold people accountable for not delivering on the ask. And so I think there is a lot of, as we speak, debate happening across the street about language in these negotiations related to tech transfer. I think one of the challenges is that when there is this very broad ask, it is easy to both push the broad ask and it is easy to push back against the broad ask, and you don't really get anywhere. So what I would say, and part of what we're thinking about, is what are the exact types of circumstances in which tech transfer is most likely to be helpful? When there's, I'm sure there's more expertise on this, but my thinking is when there's existing manufacturing capacity, when you have the human resources in place, when there's a clear, need in terms of response, and there's a market, whether that market is, donor funding or local funding for the product. So I think that, to me, and that is a circumstance that exists around the world. So let's look at those circumstances and then say, hey, here's the time when tech transfer is needed. How do we get there? And I think the more we can move toward those specific examples to demonstrate when this is going to solve the problem and when it's not going to solve the problem, the better off we'll be. We might not all be on the same page, but at the very least, we should resolve those situations.
Perfect. I think time is up, but we can take one question. Right. Okay. We're doing well. So maybe let's open up the floor if there are comments, questions. SJ. Okay, so there's a question. Please introduce yourself if you don't mind. And
one of my questions, I have a responsibility on pandemic preparedness and AMR for Cepheid. One of my questions is, how is the White House integrating AMR as a threat into some of those programs and offices that you spoke of? And then on the topic of kind of being specific, right, because AMR is very broad, how are you getting specific in those programs and how you're addressing it.
Thanks. Also a long answer in terms of bureaucracy, but we have a task force that is led by the Department of Health and Human Services, but brings in participants from other agencies, particularly USDA, given the importance of taking a One Health approach to AMR. It's called the CARB Task Force. A lot of acronyms in government, but on an ongoing basis, they develop the strategy and approach and track progress domestically and globally on the issue of AMR. Leading up to the high-level meeting, I think there's an opportunity, both in the U.S. but also with partners, to be specific about what the targets are that we are setting and moving toward, and that is something that we are supportive of, and we are engaging actively in those conversations already in New York. The zero draft of the political declaration was released, I think, last week. So we're supportive of overarching shared targets that we are trying to get toward collectively, and that obviously the U.S. is committed to moving toward, but also the specifics of the underlying targets, things like infection prevention and control that we're already working toward, but just linking it more clearly to the AMR conversation. And then, it's going to be about time to update our national action plan for the United States on the domestic front. So we're starting to work toward that. And then looking globally at what the key actions and priority actions are that we're moving forward. All of this is, you can have a strategy, but you need the resources to support implementation of the strategy. I will say that what I've heard is that AMR is a threat that invokes fear on both sides of the aisle in the United States, as it should. So the hope is that there will be sufficient resources to continue responding.
From ECPATH. Thank you so much for raising that funding is often disease specific, and for highlighting how a lot of during the pandemic was leveraged on the HIV investments that PEPFAR made over the years. One of the questions I have, or what I noted, is obviously during the pandemic, huge investments were made in additional infrastructures and systems and technologies. And when you go to the countries, a lot of them now sit at the site and gather dust. So also, how is the White House or other people, how are they thinking about using them in reverse? Like rather than just saying, okay, we leverage on the other disease areas to ensure that the skills and the technologies are maintained. What are the thoughts with regard to utilizing them for other diseases, whether it's HPV, whether it's HIV viral load testing or TB testing? Thank you.
Yeah, I think it's a really good point, and I would just add to that picture, the conversations that are happening coming out of COVID about what the right approach is for just building manufacturing capacity more broadly, and what an ideal picture looks like for diversified manufacturing capacity among other capacities, lab capacity otherwise. I think one of the challenges is that there is a lot of mistrust, understandably, coming out of COVID between high-income countries and low and middle-income countries, but also between, among countries, and a feeling that every country wants to develop their own lab capacity, their own manufacturing capacity, so that they won't have to worry about accessing, countermeasures or anything else in an emergency. And so, I think it's collectively a problem that we need to solve. What is the rational, right-sized version of all of these resources that can be leveraged in an emergency, but also serves the needs and can be sustained in the interim? I don't think it's certainly we are acknowledge the problem and want to help solve it, but I don't think it's something that the U.S. or certainly the White House can solve. I think it is, we need to have sort of a shared global vision of what the right-sized version of this looks like, and then agree to work collectively toward that vision. My view is that we don't have that yet. I don't know if others disagree. If we have it, I would love to know what it is. But I think that is the next step of, there was this reaction coming out of COVID, a lot of money, dumped on responding to COVID, this reaction, resources taken away from other really important health issues. And now we need to take a pause and say, what is the right way to do this that's sustainable?
Before we take a couple more questions, I'd like to invite my colleagues from IPPS to talk about the scorecard. So So in reality, it seems as if a lot of funding has been, like set down, but we're seeing a cliff effect in funding, right? So I think there's a scorecard that kind of outlines what the what the landscape is, especially for diagnostics. We are not as funded as it seems. Do you want to say something?
By PPS working to implement the 100-day mission for all 3 tools, but working closely with Find on diagnostics. And Stephanie, great to see you. Thank you for the great work you guys are doing and the leadership that the US is showing, I think, in raising up diagnostics and not just vaccines. We love our vaccine colleagues, but we do sometimes feel that therapeutics and diagnostics get left behind. And that was one of the key messages that came out of the scorecard. Therapeutic and diagnostics funding is lagging way behind that of vaccines. And that's not to say we should take funding away from vaccines, unfortunately. It's and we need to be thinking about the efficiencies that can be made across all 3 tools, particularly with diagnostics, I think, being right in the middle of those 3 tools, thinking about test to treat and thinking about assays for vaccine development and testing vaccine efficacy as well. But one of the core things that the scorecard showed is for the top 10 priority pathogens, as identified by WHO, we only have all 3 tools approved for COVID-19 and Ebola Zaire. And we do not have that full, and even then, those tools aren't fully available in every country in the world in LMICs. So we're really trying to raise awareness of that lack of diagnostics funding, as you're aware. There are number of other technical challenges as Find is trying to kind of troubleshoot with their 100-day mission diagnostics framework. Can I cheekily also ask a question while I have the mic, which I was going to do anyway? Because one of the things we were also thinking about, and I'm thinking about this in relation to the pandemic accord negotiations and thinking about the next, like, if there's an Act A, Mark II, the IMC-MNet conversations, what would you find it helpful to see as a government, as a donor, as a government protecting your people in terms of global coordination around diagnostics, both in terms of development in inter-pandemic periods and in pandemic response? What would be helpful for you in making decisions about where you put that finite resource and in bringing together the finds, the industries, the academics? Is there anything that we as a technical community can be doing to support you as donors to be making best impact from what we know is limited resources? Thank you.
My name is Juliana Delpino. I'm one of the industry folks present, and I just wanted to take up the invitation for us to speak up. And I think it's helpful to address some of the misconceptions that are quite toxic and often floated around about industry. My company specifically, in the COVID pandemic, we developed a vaccine that was by design meant for facilitating access in LMICs. And in fact, over 90% of our supplies were for LMICs in the end. And when it comes to other outbreaks like Ebola, almost 100% was for Africa. So I think there is a misconception there that needs to be addressed. And of course, we were able to do that because of the size and the capacities of my specific company individually, but other companies, biotechs, smaller companies, obviously do have different capacities, so there needs to be a certain flexibility built into the system in order for it to work. And obviously also the non-financial incentives are definitely important in order for industry to be able to make investment decisions in a predictable and reliable manner. So the trust in the IP framework as an enabler for technology transfers is really important for the sector. But with that said, I wanted to ask a question actually about priority pathogens. There's a lot of discussion these days about the definition of what are pathogens of pandemic potential and which should be the pathogens prioritized for a pandemic instrument. And I was just wondering, how does the U.S. government think that list should look like? What pathogens should we prioritize as a global health community in order to really be, make the most impact and be most efficient in how we allocate our efforts and investments? Thank you.
Yeah, sure. And I will forget quickly because I feel like I haven't slept a lot lately. So I actually think the answers to these questions are related because that is also what I would say. And I think some of this has been done by this great community. But, you know, one of the things that has been very eye-opening to me going from the research world to the policy world is just when I was a researcher and policymakers would say to me, do not attach a PDF. I'm not going to read it. Just 3 bullets in the email. And I thought, why are they so lazy? You know, why don't they just open up the PDF and read the PDF? That is just the reality that everyone is operating in. I think especially right now, and especially in the timeline, you know, that we have in the first term of the Biden-Harris administration. So I would say, even though on a technical level, a lot of this work has been done, I think on a higher level, very accessible level of what are the priorities and how would that protect Americans? Because the argument for resources, it's taxpayer money, and the argument for resources in a setting of budget cuts, which is where we are, we had a 22% cut to our global health security line in the most recent budget. So the argument has to link back to how it protects Americans. And I think that that can be complementary in terms of what's needed in the rest of the world, for sure. These things do not need to be in tension, but I think that case, it's important to make. I will also say that in thinking about priority pathogens, and we were talking about this briefly before, you know, making the case that there is a relatively small investment that could be made in a diagnostic, like point of care diagnostics for dengue, that would have a huge public health benefit globally is also compelling to Americans, and I think to this administration. So I think making cases like that, like there are different reasons why you might prioritize. Maybe there are certain pathogens that are very high risk if there is an outbreak, and for that reason, even though it's, you know, low likelihood but high impact, those are a priority. But also, you know, low cost, very high impact, even if there's not an immediate fear of an outbreak that's out of control. I think there are different considerations, but that type of consensus around what the priorities should be, I think would be very helpful.
I hear that question, I wish I had a crystal ball, right? You know, because I could answer and say, well, in 2025, there'll be. So I think the approach, maybe starting with what WHO did recently, there's a report that's going to come out in a few weeks' time, which is the setup done by the interim MCM net that prioritized actually looking at, you know, R&D, market access, and so on for novel corona, you know, pandemic influenza, and disease X. So, I mean, disease X remains a catch-all for everything that we worry about. We didn't find, though, we've been trying to think about this same kind of question and thinking about, you know, priority families, really using information around spillover risk for certain pathogens, looking at, you know, trends in terms of the recent major outbreaks that have happened in Africa. So we've prioritized based on those parameters. Having said that, there's some work that we're trying to do, which I mentioned before, looking at 20 major priority pathogens that the Africa CDC has, you know, is working on, and looking at these as an entry point and thinking about, you know, heat maps for the diagnostics that are there, and using these as a framework for how to understand the landscape. We are also, you know, working to develop an approach where we would look at, you know, diagnostic libraries for priority families. But also beginning to think more about respiratory pathogens, because those are the ones that have, you know, the huge pandemic potential. But also, to your point, also think about technologies that can be easily leveraged for other outbreaks that we know will happen in the more localized geographical settings, like what we saw with Mpox in DRC, and we know will happen with many other, you know, high impact, perhaps high mortality events that will happen in some, you know, far removed part of the world that nobody will care about. So, okay. So
Hi, my name is Anand Shah, and I'm working in a public health research and advisory firm. First of all, thanks, Stephanie, for the support the US government is giving for Americans and others as well. I've been in different meetings here in WHA, and I saw that the hall was packed with people talking about the latest treatments, their patient groups, the government bodies and all. And diagnostics is enabling universal health coverage and others. And I look around over here, there are some of the industry people, but those who have to make the decisions. I don't see that the value of diagnostics as a vehicle to actually help, because if you spend time over here, you will spend lesser time. There's a lot of work, put more money into the treatments. So I'm wondering, with the muscle that US government has and the money you are putting in, how are you enabling the other governments to really move forward? There was a resolution last year. We talk about 100 days mission for diagnostics we are having now. But I look at the room and the people, there are more industry people than those who are there who have to invest in diagnostics. Right from the primary care for the very, very poor countries, you need that. Also the tertiary care where you need the targeted therapies at both ends of the spectrum. But I don't see that kind of passion or people who are there in the room. So what can the US government do to help the fellow governments to really recognize the value of diagnostics?
So I will say two of the leaders in global health in the US government, Mandy Cohen, who is the director of CDC, and Atul Gawande, who is the head of the global health program at USAID, every meeting that you have with them, they will probably raise diagnostics as being important. So I think in those, and that's where most of the funding flows in terms of bilateral work and even multilateral work with other countries. So I think a lot of this happens in those one-on-one relationships and those conversations that often we don't see, but we certainly see the value and essential role that diagnostics play, and I think that we are conveying that. I will just say, since I know we're wrapping up, and I think it's relevant to this, but also important to talk about that, the investments that we are making in just building stronger health systems and primary health care and paying salaries for health workers and some of these basics that are absolutely essential for anything we're doing, including having somewhere to put the diagnostics, using the diagnostics, and having them be informative and useful in terms of the use of therapeutics or the use of vaccines. So what I have observed is, in the last few years, coming out of the COVID pandemic, there are a lot of new voices in the global health space, which is great, but also many who seem to have an impression that, we can come in and drop tools on top of a health system and they will just be rolled out and used. And as I'm sure everyone here knows, you need to do 98% of the work of building a health system, training health workers, making sure resources are in place, and then developing these tools which are essential will actually be valuable, will be valued, and will be valuable in terms of response. So I don't want to forget that part as part of this conversation.
I think I've enjoyed this conversation more than you have. Please let's give a round of applause to Stephanie, who's really taking that. Thank you.